Okay, thank you.
Good evening. This evening, we are going to look at implant choice in primary hip arthroplasty. A total hip replacement is an operation which is very successful and has been called the operation of the century. This is because of how it has revolutionized the treatment of arthritis, and it is excellent long-term results. There is this article here on the Lancet which describes the operation. One of the important things in surgery is really how to choose what to do. In the excellent book of R.M. Kirk's Journal of Surgical Operations, there's a chapter entitled Choose Well, Cut Well, and Get Well. So this really summarizes how you get good results. Your choices should be all right, and operations done well, and post-operative management done well also. We're going to look at the aspect of choosing well. The choices here depend also on what you are doing. You should have good choice of patient, and then the good preparation, and choose the right implant that you are going to use. Often, as I interact with our residents, you find that what they're interested in mainly is cutting. How do I do this operation? But it's important. There's an article written by Frank Spencer which says that good surgery is 70 to 75% decision making and only 20 to 25% manual dexterity. So decision making is very important. That's why training the mind is even more important than training the hand, and we spend the time appropriately. With regard to total hip replacements, there are many implants. Here from the National Joint Registry in the UK in 2012, there were 142 different brands of femoral stems and 119 different brands of acetabular caps. So you see the choice here is quite wide. And there are different types of implants that we have. Some metal on metal, some ceramic on ceramic, and some metal on polyethylene. And there are different combinations of this. How do you then choose which implant to use? Apart from the different implants, we have different bearings. The commonest one we use is metal on polyethylene, but there are other combinations that we use. We also have different head sizes, small and large, and different fixation techniques. Are you doing a cemented total hip replacement or uncemented one? Hybrid or reverse hybrid? What makes it more difficult is that if you look at long-term results, sometimes they are not very different. The gold standard really is the Chanley hip, and you can see 25-year results. 77 to 81% of patients not needing revision. It's hard to beat this, but the Exeter hip also has quite good results at 82% in 22 years. The Karai stem also at 23 years, a stem surviving at 96%. So just looking at these results may not help you make the decision. You still have to look at other factors. The main factors that we need in diagnosis include whether you are going to do a cemented or an uncemented one, which bearings you would use, whether you want to use bone-preserving implants. Long-term results are very important, and also looking at the evidence. There are times when you need to experiment, which means that it's an implant which has not been used much. It's being introduced, and you are being part of the system of introducing it. You are evaluating it. An example of this is I used to work in a hospital which was evaluating computer navigated joints. So we did both the hips and the knees and used computers as part of the evaluation process of the particular implant. And cost is also important. I'll go through cemented and uncemented ones because I think these are major decision point. If you do an uncemented hip replacement, the design of the stems and the caps are such that when you insert the implant, you can get initial stability, which is really a physical stability that you get a press fit. And this is a result, this is really due to the finishing that you have on the implant inserted in such a way that you can get initial stability. But then for the long term, one requires biological fixation. And this is due to the fact that the finish of the implants is such that you have areas which allow bone to grow into it so that indigitation is possible. When the implant is finished in the factory, you'll find that there is plasma spray, sort of a dust of usually titanium, which is sprayed on the implant. And then on it, you can also add hydroxyapatite, which means that this bone, natural bone, can grow onto it and you get biological fixation. There are also other issues with regard to an uncemented total hip replacement in terms of the design. Some are anatomic, meaning that there is an anterolateral bow, and there are reasons for that. Many that we use are tapered and some are cylindrical. There's also the philosophy of fixation. Is it metaphyseal fixation that you have for the stem, or metaphyseal diaphyseal, or sometimes just diaphyseal fixation? And then whether it is cobalt or titanium, that's important in choosing. With regard to the caps, apart from the finish on it, there may also be pegs or spikes or screws or threads for supplemental fixation. Screws can be used sometimes. Usually for a primary hip replacement, I don't use screws. It's very unusual to use that. And that's because the screws have also their risks. You can get neurovascular injury if, I mean, it's possible to do that. Also, fretting wear. And in doing a total hip replacement, a total hip replacement, there are just a few steps. Basically summarized that you prepare the acetabulum, you prepare the femoral canal, and insert the implants and close. So it's quite easy. The steps are straightforward. With regard to cemented total hip replacements, it's important to remember that cement is a grout, it's a filler, it's not a glue. Fixation is achieved by mechanical interlock rather than by adhesion. So it's very important to have good bone preparation so that the bed on which to apply the implant has been prepared such that cement intrusion would occur. This cement intrusion creates good micro interlock for good fixation. It's important to remember that the surgeon provides the interfaces. When you have a cemented implant, you have two important interfaces. There is the cement bone interface and the implant cement interface. And the surgeon manufactures this at operation. And it's very important also to have the correct cementation technique, and at least use the third generation cementation techniques. The famous name is Barak, who has done a lot of work on this. So then you can see that when you are doing a good cemented total hip replacement, there are additional steps. With regard to the acetabulum, you do keyholes for better cementation. Then you may have a flange which you need to cut. There is mixing, which is better done with vacuum mixing. You may need to use pulse lavage to prepare the bone bed well, and some will just dry it and use hydrogen peroxide swabs and pressurization. The same with the femoral canal. Essentially, to get a good cementation, you need to have a cement restrictor. Prepare this with pulse lavage. You dry the canal, and then we on the stem put a distal centralizer, also a proximal centralizer. Is vacuum mixing and retrograde introduction of cement, meaning you need a cement gun so that cement is introduced in a retrograde manner with pressurization. So you can see that doing a cemented total hip replacement well is an exacting technique. Another important thing to remember about cement is that there are different philosophies of how it's going to work. Basically, the choice as to whether you need a taper slip or a composite beam. The taper slip, really like with the Exeter, for instance, or the system, it's made such that the cement, the implant will settle into the cement. In fact, the centralizer you have at the end, the main function is not to centralize the stem in the bone. It's really to allow for some settling of the stem. So what it does, there's an important mechanical reason for that, which I'll come to in a short while. The composite beam is different, and this design is such that you make one beam, the implant together with the cement and the proximal femur. The best example of this is the Chanley stem. I'll talk a little bit about the taper slip. In terms of the Exeter, you have a double taper. The important thing is that at one bears weight, the shear force or the shear stress is converted to radial and hoop stress. The important reason, the importance of this is that the proximal femur is uniformly stressed, allowing good stress there so that there's no stress shielding proximally. Then you have to think about the polyethylene, and there are different types of polyethylenes that you use. Some have a flange, some have a long posterior wall. The other important thing is whether they're cross-linked, and whether highly cross-linked or different types of cross-linking, which is very important more recently. So that is the cement. So if you're choosing cement, you also choose the implants which go with that and the philosophy of fixation. Then you look at the bearing surfaces. The gold standard really is metal on polyethylene. However, as time goes on, and because of wear of the polyethylene, it has now been improved with gamma irradiation so that you get a cross-linked polyethylene. Then the other bearing surfaces, like metal on metal, is an important one. Metal can be finished so that there is very low wear. And if you compare that with metal on polyethylene, that on metal is really low. And because metal is quite strong, you can have a very thin shell, allowing use of large bearings. Large bearings enhance stability and allow a large range of movement. Also, such bearings are self-polishing, which means if there's a little scratch, it is polished, allowing self-healing of the surface. However, there are concerns about cobalt and chrome metal ions in the blood and the urine, and in some cases there have been pseudotumors, allowing and causing caution on such implants, especially in the UK. A lot of these were, the use of this was really reduced because of these issues. Ceramic on ceramic or ceramic on poly, also important. And more recently, also there's oxidized zirconium metal, like oxinium. This really has the wear resistance of ceramic without being brittle. Then the other aspect is choosing whether you are conserving bone, and there are implants which do that. On the left here is a resurfacing implant, and you can see here that the proximal femur is preserved. And if in future one had to do a total hip replacement to revise this, the proximal femur is basically virgin. There are others where there is a metaphyseal hip arthroplasty, like the meta hip, and you can see just a short stem. So really, depending on what you want to do, you can choose the implant on the basis of what you have shown up. But apart from this, we have other factors for which come into play when you are choosing an implant. Long-term survival. Now, I picked this from 2004 Swedish Ship Register. And here you can see a Kaplan-Meier plot of long-term survival. And you can see, especially on this one, the top green line is all revisions. So all the revisions, all the primaries that they had, and that is what the revision line looked like. And this here, we are looking at patients under 50 years using uncemented implants. And you can see that the revision is more than for the other population. So here you can have some caution of using uncemented implants in younger patients. But the picture is not finished because you have to look at those who have been cemented, but also younger patients have greater demands on their prosthesis. Now, the other aspect is what has been done with these registers in various countries. In Sweden, they have, who started the hip registers more than 40 years ago, they have changed the way surgeons there choose implants. They do fewer different implants, but also the register has influenced, has improved the results over time. I put the funnel plot on the left because it's very important in places where implants, in places where there are registers. For instance, where I used to work, we used to get this plot every 3 months. All the dots there are different surgeons. And in this case, in this case here, is the number of procedures a particular surgeon does against the revision rate. And the green diamond there is for a particular surgeon. So we could get this every 3 months, every year, every few years. Now there are some who are way beyond that. Those are outliers. And in our case, the outliers got a letter from the equivalent of the KOA asking you to explain why you are an outlier and whether you need support. And support will here mean that you could go and work with a surgeon who is somewhere who is not an outlier. So this influences how joint replacements are done in a particular country. So you can find that in Sweden, 6 different stems account for more than 92% of all femoral implants, and only 10 different cap designs in a 2%. And if you look at that, like one of the things is the Karai stem is used in 59% of all uncemented stems. And if you look at the cemented stems, they use only 3. And this is the influence from the register. In the UK, what is in the register is evaluated, and there is a panel called Orthopedic Data Evaluation Panel, or the panel. And this panel looks at all the literature regarding follow-up of patients for each particular implant. They look at it pre-entry, that's less than 3 years, at 3 years, the performance, 5, 7, and 10. And then they look at the quality of the evidence for this follow-up. And so they would give a particular implant a particular rating. Like an implant will have 10A, meaning it has been followed up for at least 10 years with good evidence. So implants all will have an ODEP rating, and this sort of influences which implants one would use. There are also guidelines. For instance, in the UK, the NICE, National Institute for Clinical Excellence, recommended that surgeons should only use implants that have high quality long-term data with a minimum survival of 95% at 10 years. You can also use new implants, but the new implants are used in a setting where there is monitoring. A small number of selected centers, small number of surgeons will study this. Patients will be enrolled and they'll be informed that this is a new implant. We don't know the long-term results, and they can be able to either accept that they use this or not. And then you collect the results from that. In our environment here, we can also look at implant costs. We have not looked at that because here mainly many of the implants we have here are uncemented, which tend to be more expensive than the cemented ones. There are also local considerations. One of the things that I found when I moved back to Kenya was that implants were not held by the hospital. You called a vendor who brought the implants, and sometimes what you thought was there was lacking. And sometimes you just know it at the time when you need it. You have gone to operate on the patient, you have opened up, you have done one part, and then the next part, something is missing. Something that is very, irregular really, which is criminal, not to have everything. So you may decide here to choose a product because of the support, that the supply is there reliably, that if something is missing, you are told beforehand, not at the time when you are already operating. Also, the equipment that is used to insert the implant is an important consideration. Some implants have really good equipment which allows you to insert it in a reliable manner. The other reason is the availability of implants. I was quite happy doing cemented hip replacements, but locally I found that it's quite a challenge to do a good cemented hip, to find the right pressurization equipment, and it was a challenge. So because of that, I started doing more uncemented hips. Also depends on the technology that you have. I've mentioned about computer navigation and others. So with us, how should we choose locally? The question is whether we have capacity to experiment. If you experiment, you should have a high number of joint replacements you are doing, which can be followed up so that you can pick any issues. I think we do not have the capacity to be able to experiment. So locally, I think it's important to look at the evidence. What are the long-term results of a particular implant? Also, I think we should be going to a situation where we can also follow our outcomes locally, and probably also look at how we could have a hip implant registry. This will help us to track and see which implants are doing well, and how we should in the future, which implants we should select in the environment. Thank you very much. I think my time is off. I was given 30 minutes. I think that is it.
All right. Thank you, Dr. Oroko, for the nice presentation. Are you able to access the chat?
I think you'll help me with that.
Okay. Okay.
I'm not as tech savvy with regard to this.
All right. So
yeah.
there is one question for you from Dr. Singh. He says, thank you, Daktari. Do you routinely use hydrogen peroxide in bed preparation?
That is a good question. I haven't used it for a long time. I used to use it. It's more historical. Those who used it said it was very good. It looks nice, but there is really no evidence for to support it is used. It just looks nice. The answer is no, because these days I hardly do cemented implants.
Okay.
Yeah.
All right, then. Thank you. I do not seem to have any other questions.